They do make the lights here very bright, so I can't see any of you yet. But thank you for coming and joining us here right at the bitter end of the HLTH conference. I'm Matt Herper. I am a senior writer, medicine, and editorial director of events at STAT, which I hope you all read. It's a great medical news publication, and we're here to talk about one of the most exciting topics, I think, in medicine now, which is the idea that in a few years, maybe even now, people will be able to get a blood test and find out, or be screened for, really, cancer. And not just one cancer, but many of them. And so we're going to talk to the two companies that are really leading the way in this space. First, I'm going to bring out Joshua Ofman, who is the Chief Medical Officer of Grail. And then in a bit, we'll get to talk to the CEO of Exact Sciences, Kevin Conroy. So thank you all for being here. Josh, come on out. And for all of you, I do have Slido here, so go ahead and send in your questions, although it is not disconnected, so great. So I think first we should give people a grounding in the idea here, which is really a big idea, which is that there are these little bits of DNA circulating in your blood, and that can tell you, not with perfect certainty, but that it can detect cancers that you'd otherwise miss. So explain for people just a little bit how this works.
So we've known for some time now that when cancers grow in the body, cells are turning over and dying, and they're releasing little bits of DNA into the blood. And I think in 2015 or so, it was very clear that we could harness that DNA that's circulating in blood and interrogate that DNA. And to Grail's great credit, it was before I joined the company, they did a very unbiased R&D study. And they asked a very fundamental question. If DNA is circulating in the blood, what is the best way to examine that DNA to find signals of cancer? And so they did a head-to-head comparison where they looked at mutations at much deeper sequencing depth that is even available today, chromosomal abnormalities like copy number variations, and fragment length, fragmentomics, and they looked at methylation patterns. Methylation are these little methyl groups that attach to DNA and turn genes on and off, but they don't change the code of DNA. And in that study, it became very convincingly clear to those at Grail that these methylation patterns could detect signals of cancer that are common across many, many cancers. And then the methylation pattern is also able to have a fingerprint for where in the body that signal comes from. So that was the big R&D study that was done, and that was the way that Grail found to develop its assay for a multi-cancer early detection test that with a simple blood draw can now detect over 50 different kinds of cancer and localize the cancer signal to the very specific tissues or organs where that signal came from.
And how accurately can it do that? Because that's one of the problems. One of the fears of a test like this is that you'll find out you might have cancer somewhere in your body,
right,
and we can't tell you where. That's a terrifying thing, right? Like, and every ache, is going to seem like it might be a tumor. So how well can it localize the cancer?
So it turns out that these methylation markers are among the most sensitive markers of tissue type in the body. And so when we see a fingerprint, when we determine, so the test is a two-stage test. You draw the blood, you sequence the DNA, and the first step is there a cancer signal, yes or no? And that's done with a machine learning algorithm that classifies the signal as cancer or non-cancer. Then if there is a cancer signal detected, there's a second step. And it's a different machine learning algorithm that then classifies where in the body that signal comes from. When there's cancer, it is over 90% accurate in detecting the location. So it's a very simple test report. It's not one of those 12-page reports with 1 million mutations that nobody reads. It says cancer signal detected, predicted origin, esophagus or liver or uterus or ovary or pancreas. And so doctors really know what to go do. They know how to go image or investigate those areas to see whether there's a cancer present or not. And then only if there's something present would it get biopsied and a cancer diagnosis would be made.
So if there is but the other problem, the other fear with a test like this is false positives. And in your studies, you find about as many people who don't have cancer, or you can't find the cancer, the test says they have cancer, even though you have a very high specificity because most people don't have cancer, right? So like if you test a lot of people and you have a very low false positive rate, you're still going to get more positives than cancer. So how do we deal with that? How do we deal with finding out that, because it still really means you might have cancer.
That's right. So it's a really good question, but let's take a step back for a minute and remind ourselves what we're doing. So, cancer, we've been fighting a war against cancer for decades, and it's not a war that we're winning. Despite all the advances in therapeutics and in screening, we are finding most cancer too late. And that's because most cancers are not screened for at all. We only screen for 5 cancers, and we screen 1 cancer at a time, okay? Let's just go through that for a minute. Mammography, really important screening test. The likelihood that a woman with a positive mammogram has cancer is 5%, okay? 5 out of 100 women with a positive mammogram will have cancer. Low-dose CT for lung cancer screening in smokers. If there's 100 positives, only 6 will have cancer. So for Gallery, which is a very unique, innovative approach, multi-cancer, if there's a cancer signal, you almost have a 1 in 2 chance that you have cancer. So it's an order of magnitude more powerful than anything we've ever seen before in screening. And the big idea is this: we can, instead of only looking for individual cancers, in addition to that, now we can look at individuals for cancer. Because I don't get to choose, you don't get to choose which cancer you're going to get. You don't get to say, I want one of the screened cancers. Make sure I get that. That's not how it works. We don't get to choose. So by adding a multi-cancer early detection test that can screen you as an individual for cancer to the single cancer screening test, not only can we dramatically improve the number of cancers that we find in the population, but we can find them early when they're treatable, pre-symptomatic, and often curable, at least for the solid cancers.
And so one skepticism you will hear from people in cancer screening is that we've had the experience of things like PSA, where we found out that if we overdid it, we overtreated. How do we get data to show that this works the way you think it does?
Well, so you're bringing up, you're raising the 2 most common harms that are associated with screening. The first is false positives. We just talked about that. Our test has a false positive rate of about 0.5%. That compares to 10% or more for single cancer screening. So the second harm is this idea of overdiagnosis. Are we just finding the cancers that aren't going to cause harm, right? That you're going to die with rather than die from, and that's the issue with prostate cancer. So here's what we know, and there's a lot of data, it's been published about this now. Here's what we know. When you have circulating DNA from cancer in your blood, that means that you have an invasive, aggressive cancer. In fact, the indolent cancers, the ones that are slow growing, not going to kill people, they are not shedding a lot of DNA into the blood. And our sensitivity for those indolent cancers, prostate, encapsulated prostate, slow-growing thyroid cancers, slow-growing hormone-positive breast cancers, our sensitivity is very low because what we're measuring is DNA in circulation, and those tumors are not shedding a lot of DNA. So when you look at the survival curves of the cancers that Gallery detects, it looks just like the SEER registry, exactly what you would expect. When you look at the survival curves of the cancers that we don't detect, because there's not enough DNA in the blood, their survival looks much better than anything you would expect at every stage. And that's now been published, and I think it tells us that we're unlikely to contribute to this problem of overdiagnosis.
Will we get randomized data on the benefits and risks of this test, and what will it look like?
Absolutely. So what we've done to date, Grail, to its large credit, years ago undertook one of the largest clinical programs in genomic medicine that I'm aware of. There was a large 15,000 person study called the Circulating Cell-Free Genome Atlas, which enabled us to develop and validate the test.
And just so people understand, this is actually an AI looking at these methylation patterns and got better over the process of that. So one of the frustrating things for me as a reporter was I would go and see data, and people at Grail would then tell me, well, but it's better now. And it was already
because you're training, right? So if you do it right, what you do is you have independent training sets to train these machine learning classifiers, and then independent validation sets to actually validate them. And Grail did 3 sub-studies just like that. So done in the most rigorous way, unbiased, and let the science decide what our approach was going to be, and methylation patterns was the winner. And then we've done multiple cohort studies. We have over 340,000 people right now in clinical studies. So we have observational studies and we have interventional studies. We just published a 6,500 person interventional real world study in the United States. Again, we developed this test in collaboration with some of the world's leading institutions, Mayo Clinic, Cleveland Clinic, Intermountain Healthcare, Dana-Farber. And these institutions screened 50-year-olds and above adults with no suspicion of cancer, and the test performed exactly as we expected it would. We found early cancers that were treatable and curable. We found specificity just as we would expect. The positive predictive value was between 40 and 50%, just like it would expect, and patient satisfaction was very high. That was all just recently presented at ASCO. But more than that, we have a randomized clinical study of 140,000 adults between the ages of 50 and 78 in the UK's National Health System, where it's a pragmatic randomized study, the biggest of its kind ever done. And it's already enrolling and enrolled an incredible number of people already in its first several weeks. And so we're going to be sitting on a mountain of randomized clinical data within about 12 months. And then we're following it out for 3 years to understand the NHS's goal is to reduce the percentage of cancers that are detected in their late stage. And we're going to demonstrate, and it's powered to demonstrate a reduction in late stage cancer diagnoses.
So starting out, who should get this test? I mean, because one of the things you talk about that positive predictive value, but an easy way to make that go up would be to give the test to smokers, right? People who are at high risk of cancer, for people who are older. So who should be getting it now? Why not start off by looking in the places where you're most look under the lamp, right?
That's right. And we are doing that, absolutely. So Gallery, which is Grail's multi-cancer early detection test, was just launched in June. And it is intended to be used in adults with an elevated risk of cancer, such as adults over the age of 50. Here's what we know. We know that age is the strongest predictor by far of cancer risk. It overwhelms almost everything else. And by the time you're 40, your risk starts to increase. When you hit 50, it starts increasing very fast, and then it rises like a hockey stick. So what we've done is we've said, let's focus there. Adults over the age of 50 who have about a 13 times higher incidence of cancer. But then we've asked the question, and we don't promote this, but we've asked the question, we know there are other elevated risk groups as well. Smokers, for example, they get aged. In fact, a 35-year-old smoker has the same cancer risk as a 50-year-old. A 35-year-old cancer survivor has the same cancer risk as a 50-year-old. Obviously, people with genetic syndromes and hereditary cancer syndromes are at very elevated risk. Obese diabetics are at very elevated risk. Transplant recipients on immunosuppression, very elevated risk. People with HIV, people with hepatitis C and HPV are at very elevated risk of cancer. And so these are elevated risk groups that doctors will consider when they think about how to use these types of multi-cancer detection tests.
Some of the competing firms in this space are developing blood tests that might work as multi-cancer assays, but they're focusing on one cancer initially, often a place where you can screen, like lung cancer, so that the test can be kind of a prelude to the screening technology that already exists. Why is Grail choosing to do this approach, which is really a multi-cancer approach followed by scanning if something's found?
Well, we followed the science. So what we learned in this discovery effort was that there is a common cancer signal that is circulating in blood. If you take a step back and you think about it, the blood is an incredibly powerful aggregator of biologic signals. And so we've harnessed that signal, and we are finding a common cancer signal. And people ask us all the time, why aren't you just looking for lung cancer or pancreatic cancer? And the answer is because that's not what we're seeing. That's not the way the biology is working in the body. We're seeing a common cancer signal, and then we have the ability to localize that signal to different tissues and organs. And so that's a much more powerful approach. So that's the first answer. The second answer is we are a public health company. We are trying to dramatically improve the public's health by reducing the burden of cancer. And we will not do that one cancer at a time. There are very good screening tests for lung cancer, for breast cancer, for colon cancer, and even for prostate cancer and cervical cancer. The big value of Gallery will be in all the unscreened cancers. So of the 50 cancers we know that we can find, 45 of them have no available screening today. That's where the value is. And by adding that to the single cancer screening, we can increase the cancer detection rate in the population dramatically. And if we do that, we will have a shot at trying to bend the cancer mortality curve. We will not single cancer screen our way out of this problem. It will never be cost effective to screen for all these single individual cancers. And nobody's doing the math. So if you're a female and you get lung cancer screening, breast cancer screening, and cervical cancer screening, your cumulative false positive rate is over 45%. So we're not thinking, we need to move away from the single cancer mindset and start thinking about finding cancer in individuals.
And so, and you talked about detecting early cancers, but you still detect them more often as they're later. Are we at the point where we're really detecting them early enough to make a difference with this test?
Well, we have found that, I'll give you an example. We have a pre-specified subgroup of 12 of the deadliest cancers that we know account for about 2/3 of all cancer deaths in this country. For that subgroup of cancers, stage 2, which are localized, potentially curable solid tumors, we find 70% of them at a specificity of 99.5%. Okay? That's unparalleled. Nothing's ever been seen quite like that before. Stage 1 cancers, less, because again, what we're measuring is the amount of DNA that's in circulation. And so the ability to find localized cancer, stage 1 and 2, and even stage 3, by the way, given the adjuvant therapies that are available now with biologics and the extended survival in stage 3 cancers, finding all of those is really important for individual patients and their families. And it will result in a big improvement in outcomes.
All right. Thank you so much for being here. This was a lot of fun.
Thank you
Great
very much.
seeing you.
Thank you.
Hey, Kevin. I'd like to introduce Kevin Conroy, the CEO of Exact Sciences.
I didn't know if you called my name.
You didn't hear it? No? So welcome to part 2.
Wait, time out. Who wants to follow Josh?
Well, I thought you did.
Not anymore.
Oh, well, I think he set things up for you rather well, in fact. So Kevin's company is the other big player in this space, and they bought a competitor called Thrive Earlier Detection. So we're going to talk about liquid biopsy, but I actually don't want to start with liquid biopsy because you built this company with a different product that people may have heard of, which is Cologuard, which is a screening test for colon cancer. And so what makes you different from what we just heard is that you've got some battle scars. I was covering you at that time, and I know that launching that test was not the easiest thing in the world. It was a hard thing to make successful. Which you'd think, that there's both the, do you want a colonoscopy? But there's also the issue of a lot of people don't get screened. So you'd think that a new way of screening would be rapidly adopted, but that wasn't what happened.
Anytime you go into screening, you need a combination of incredibly strong science, clinical evidence, and public policy. Mm-hmm. And then even if you have all of that, there are forces that push back against the early detection of cancer. The great thing is the experience with Cologuard, we believe has created a lot of innovation in this field, including multi-cancer early detection, mm-hmm. investments, and that Cologuard has been successful despite a lot of work and challenge, is encouraging a lot of others to get into the space. And I think Josh is exactly right that it is ultimately, if you're going to solve the problem of cancer, it is going to start with screening, and not screening for just individual cancers and individual organs, but screening people mm-hmm. as a person, mm-hmm. because it's that cumulative prevalence of cancer that you're looking for. And it means that if you screen for all cancers, the number of people you need to screen to find one is dramatically lower, which moves multi-cancer screening towards cost savings. And there isn't another single organ approach that is cost saving. They all cost money to ultimately find a cancer earlier and leading to life years gain. Mm-hmm. With Cologuard, I mean, I'll never forget in 2009 walking into Dr. David Ahlquist's office at the Mayo Clinic, and his pitch was, we can reinvent colon cancer screening with a non-invasive, accurate, at-home way to screen for cancer using the power of DNA methylation, mutation, and protein. Mm-hmm. It was pretty far out there. Then he went even further out there and said, and then we can do a blood-based he called it a pan-cancer screening test with the power of these DNA methylation markers, which at the time there was not a lot known about them. That led to Exact Sciences really coming into a rigorous focus on bringing Cologuard to patients and physicians. And now we've had over 10 million Cologuard test orders, and it keeps growing at a rapid rate. And
what was the worst part of that journey, though? It was...
None of it it's been hard. It's all been an amazing journey, from mm-hmm. the science, which was really cool, to running a massive 10,000 patient clinical trial, which even the FDA thought was ambitious. Getting into the key guideline, mm-hmm. USPSTF, so the United States Preventive Services Task Force, is the guideline group that all roads lead through.
And probably the toughest guideline. I mean, I joke that no doctor actually they follow it for everything but their specialty, right? Like, it's a very strict, hard guideline to get into. And you didn't initially. So they issued these draft guidelines, and I was in Ireland celebrating my 50th birthday. And I was at the Cliffs of Moher, which are like 400 feet straight down to the ocean. I'm glad you didn't jump.
I got the call that the guideline group said we didn't initially pass muster. We didn't have a second study. They wanted two, mm-hmm. we had one. It's one of the reasons having multiple aspiring entrants is important. But that was a bad day. 6 months later, a second study was published with Cologuard, showing even better data than the initial study, and they actually changed their mind, which they rarely do. We made it into the guidelines, and that triggered broad-scale commercial insurance coverage, which is going to be key for multi-cancer early detection. Mm-hmm.
That's a good point to underline, that unless this is paid for, people aren't going to get screened.
Yes.
So then, more recently, flashing forward, you saw Thrive, and you saw the data that was coming out. And you were already in this space, you'd been talking about it forever, but you saw this new company come along that had found very recently, just in the past few years, that had this long-standing research that had been going on, and you decided to buy them? What drove that decision?
We had been doing research with the Mayo Clinic and identifying in the 18 deadliest cancers the DNA methylation markers that are the most specific. Present in cancers, not present in no cancer. We went cancer by cancer, tissue by tissue to find those markers. Bert Vogelstein in his lab was looking at this from a curated DNA mutation standpoint and protein.
Mm-hmm.
And so when he did a really big study, it had a large impact, formed a company.
Mm-hmm.
We invested in that company. And then ultimately, as a study was published called the DETECT-A study. So it was the first time that a multi-cancer early detection test was studied in a population of 10,000 average risk people.
Mm-hmm.
And the study read out strong. It doubled the number of cancers found compared to conventional screening.
Mm-hmm.
At that point in time, we said, what we'd like to do is combine the mutation and protein approach with methylation, put those together into one test.
Mm-hmm.
And that's where we are today. And we're confident as we go into study a population of around 100,000 people randomized in the US, we expect that to ultimately lead to a transformation in cancer detection. And our goal is to ensure and to make sure that earlier detection becomes part of the standard of care.
Mm-hmm.
It's going to be another long process. This is not going to happen overnight.
Let's talk about the role of PET scans in this process, because that's something that that I've heard a lot about. What is the role of PET scans in this test as it goes forward? Does everyone need one? Like, how is this going to work?
There are two basic approaches that you can go down. Tissue of origin, which Bert Vogelstein initially
Mm-hmm.
dreamt of and discovered and implemented, or PET CT.
Mm-hmm.
And ultimately, and I wasn't originally convinced of this, but ultimately became convinced that the safest and most efficient way to determine whether a patient has cancer
Mm-hmm.
is if blood marker positive, to get a PET CT, which then determines whether there is cancer.
Mm-hmm.
So that you can give a patient confidence with a very sensitive and specific methodology that is standardized to ensure that that patient that is truly negative can go about their life not worrying whether they have cancer. And it doesn't lead to a lot of additional kind of a medical mystery.
Mm-hmm.
I don't know which approach is ultimately going to be the most widely utilized, but it's really important, we believe, to go that safe and efficient approach. It also leads to a very, very small false positive rate, like 0.4%.
And so what do you do in order to, you've got that small false positive rate, but you still have that problem. Like, what populations do you go into initially? Who are the right people for this test? Who are you studying in that big study?
We're studying average risk people 50 and older, probably between the ages of 50 and 75, maybe between the ages of 50 and 85, which is what it is for colon cancer screening. And ultimately, that may come down to 45 or even 40, because we know that for many cancers, incidence is rising in younger people. So it's average risk people. Ultimately, high-risk people may need to be screened more frequently. But if you're going to go and address cancer, you really have to screen a broad-based population like we do today for breast cancer and cervical cancer and colon cancer and others.
What is the, so since you guys both came out, since Thrive came out and Grail was actually out first with, founded in a very big, impressive funding round not that many years ago, spun out of Illumina, the DNA sequencing company. But in addition to these two players, I'm seeing a lot of companies entering this space and entering the space with various other technologies that they think might be even more sensitive and also might be cheaper in terms of whether you're using proteomics or methylation or any of these technologies. There's going to be a problem with these tests of how much does it cost to do all of that, right? Like there's the both your margin and the overall cost. How do you feel about the competitive situation? Do you think by doing these big studies, you're creating a wall of data that'll keep others out? Or are we going to get a whole bunch of entrants after you've kind of built the way in?
Well, I think the fact that, first of all, we in 2010 started on this journey of multi-cancer early detection. Right. Grail came in and got really aggressive about the studies they were doing and advanced the field. And then Thrive came in and advanced the field. And then we found out, wow, maybe we're a little behind. And now I think that we're in the lead because of where Thrive is with the completed study and with technology that we believe will be incredibly sensitive. With that said, the technology is going to change every 5 or 10, and certainly over the next 20 years. And what we're building at Exact Sciences, and what we've built now, is a 6,000 person company. When I joined, there were 3 of us. And we're building that with an incredible IT infrastructure connected with the health systems. We're built on Epic. We have a 1,500 person sales and marketing organization because we're going to have to educate physicians and health systems all over the country. We have 2,500 laboratorians and 700 customer care people. So we built this, we've invested about $500 million in the customer service and IT capabilities so that we're able to deliver a test, go from a test order to a test result right within your electronic medical record. So we think that we will have the ability to bring in additional technologies if they're able to improve the sensitivity and specificity of a test. We want to be the company that then goes and runs the 100,000 patient clinical trial to prove that out. And it comes back to that science. If the science is there, you have a moral obligation to keep pushing it forward.
If this doesn't work, if we don't have, not only if your test doesn't work, but if all these efforts at multi-cancer early detection don't work out for some reason, if we're looking at medicine in 10 years and this doesn't exist, what went wrong? Is there no chance that this isn't going to happen, whether it's you or someone else, or is there a situation where we find out something about this journey where it's just not going to work out? Like, what's the...
No, I wake up in the middle of the night all the time worrying about the things that might not work out. First of all, the science is there. As Josh said, look at the work that has been done, really multiple companies. I think Exact and Grail and Thrive being the leaders. But ultimately, there's a public policy decision that needs to be made. And that public policy decision is, are we willing to invest in the early or the earlier detection of cancer? And so that means Medicare coverage. The law has to be changed. So there is legislation that could allow Medicare, provide Medicare the authority to cover a test. Today, they don't have the authority to cover a multi-cancer early detection test. That doesn't exist. Getting into the guidelines. To me, it's really more the public policy piece, not the science piece. The science is there. You could implement this tomorrow and you would start to have an impact on shifting the detection of cancer from later stage to earlier stage, thus leading to very different outcomes. And then the other thing is bringing the cost down so that you can make these tests available all around the world. Cancer is increasing as the population around the world becomes wealthier and lives longer. And we have an obligation to make sure that this technology is available in a cost-effective way in the US and all over the world. And so that's an important thing that we have to worry about is how do you do that? Can you do that? This is DNA sequencing. It's not cheap. So we need to bring those costs down to the point that you can make this work. Now, with that said, I am an enormous optimist that all of these pieces will come into place, and everybody in this audience eventually will get a multi-cancer test.
Is the U.S., how is the U.S. in terms of being ready to implement those public health decisions and those public health actions compared to other countries? I mean, I kind of actually wish Josh were up here because we could ask about the UK, right? But we're noticing a lot of population level thinking coming out of NHS. Is our fragmented healthcare system set up to deal with benefits like this?
It is, in part because multi-cancer screening is less expensive by far than cervical cancer screening, breast cancer screening, colon cancer screening, because again, that the significant prevalence. Approximately 2% of people over the age of 50, somewhere between 1% and 3% have cancer and don't know it. So if you can find those and treat them potentially with curative surgery, it's a lot less expensive than treating with an immunotherapy stage 4 cancer. So is the public policy going to get there? There's a lot of work that needs to be done from a health economics perspective. I think it is going to get there, and it's going to get there in the US. I think it's going to get there in the UK and beyond. Is it going to take 10 years? Yes. Is hard a reason not to try? No.
Okay. It's harder reason not to try. And so hard's not a reason not to try, but 10 years. Are investors ready for the journey they're going to go on? I mean, you must have had some really interesting experiences in those. I know I've talked to you about some of them with Exact being publicly traded as you were launching Cologuard. But are they ready? Are they buckled in sufficiently, I think?
They are. I go back to 2009 when I joined Exact Sciences. It was a $30 million market cap company with $30 million in the bank. So investors weren't exactly valuing Exact Sciences as...
They expected you to waste that money, evidently, if you were being traded at cash.
And, you know, the successes that we had along the way, and it's something that we're really proud of, created an environment where investors started to believe in cancer diagnostics and the power of earlier detection and therapy selection. And now it's a whole different world than it was 12 years ago. And that is an important part of the ecosystem because it provides us the capital to run large studies. And so
the capital these days is really, I mean, the amount of money that companies now raise that I ignore always shocks me, right? It used to be, if someone raised that much money, you'd do a story, but it's every day now.
I mean, investors believe. And so, yes, they are willing to invest for a 5 or 10 year horizon. And the great fortune of that is it's going to be the fuel that provides an impact on cancer like I think we've never seen. And I think if you look forward 10 years out and beyond, you're going to see curative surgery become a much more frequent treatment than it is today, where frequently it's not an option. And I just had lost a family member to colon cancer, and I'm still trying to digest this, when there are so many screening options available. And by the time it was really ascertained, there weren't many options. There really weren't any options. So there is a new world coming. This new world there's going to be you know, there's Grail and Exact and a lot of other companies who are going to play a role in it. Many of them IT companies that help make this process go so much easier. And so we're just proud to be part of it.
Thanks for sharing. And thanks to all of you for being here. I think this closes things out.